Hi AOPA 2020, Steve Hughes here, Senior Orthotist for Polio Services Victoria at St Vincent's Hospital, Melbourne. Having used the BTS G-WALK throughout the last 4 years or so at our polio clinic, I've been asked to provide a few insights to its use and usefulness for our clients and clinic. G-WALK is a wearable inertial sensor designed to report spatiotemporal and kinematic data about someone's gait. As you can see, it's really small and unobtrusive, and compared to the instrumental walkway we used to use, it's really quick to perform an analysis and acquire usable data. G-WALK has become a key part of our multidisciplinary clinical assessment, and I appreciate that it's easy to perform an analysis within the context and time frame of a clinical appointment. Once you've done one run through, it's even quicker to repeat the process to get some data on a change, like adding a crutch, changing ankle range of motion, or even adding a build-up. When required, G-WALK's reporting is modern and well laid out, allowing you to provide before and after data to educate your clients and justify your funding. We make a lot of use of the comparison view, which uses graphs to visually overlay results of different metrics. This allows us to demonstrate the influence of various situations on their gait. And this is just moments after the G-WALK test is finished. We also find the G-WALK's portability means that it gets used in more situations because it can be taken to where the patient is. For us, that means we can acquire gait data when we are running polio clinics throughout Victoria, and that reduces the discrepancy between the quality of care our regional clients receive compared to those who attend our clinic in Melbourne. All these benefits are achieved with a validated 97% accuracy with the research gold standards of gait right walkways and 3D gait labs. Although over the years I have discovered a limitation with some spatial measurements on clients with joint contractures, such as the step lengths. But even in these situations, the G-WALK remains internally consistent, so I can trust its evaluation of a change in a positive or negative direction, even if the exact figures are out slightly. Our physios like to use the built-in outcome measures, particularly the timed up and go or the 6-minute walk test to monitor function, balance, falls, risk and fatigue. It can be worthwhile using these outcome measures before and after treatment when it relates directly to your client's goals. It's important to be aware that instrumented gait analysis gives you data, not answers. It requires a decent understanding of gait and a time investment to understand the system, because you need to think to interpret the data that the system produces. I'm using the data to provide colour to the story I'm telling, and the story relates to the client's problem and what we're going to do about it. The numbers you get are just numbers until you give it meaning. So, in our polio clinic, each physical assessment is accompanied by a joint P&O physio gait assessment, which involves gathering data with the G-WALK and a brief 3 to 5 second video recording from 3 angles. Of all the metrics that the G-WALK measures, I'm particularly interested in step length, left versus right, the cadence, speed and step length relationships, stance phase percentage, and pelvic tilt, obliquity and rotations. For our polio clients, I often start by looking at step lengths and stance durations. Clients seem to easily understand the key aim of wanting to increase the confidence they feel in their weak limb so they don't need to compensate with their better leg quite so much. Here's a quick example of the G-WALK in use in our comprehensive assessment clinic. Mrs. S is a 62-year-old female who contracted poliomyelitis at the age of 1. Her right leg was predominantly affected, and today the main weaknesses she has are knee extensors, dorsiimplantar flexors, as well as hip abductors. The right leg has manageable knee and hip flexion contractures. It's now weaker and shorter than the left. Her self-reported walking capacity was 600 metres on a good day, but only 200 metres on a bad day. She reports to trip regularly and had 2 recent falls. Her main concerns when she presented to our clinic were the right leg weaknesses. She felt that her left leg was beginning to struggle, and that's probably overuse symptoms, and significant back pain on the left side. She is not suffering from post-polio syndrome, but this is a classic presentation of the late effects of polio, where the wear and tear of a compensated gait means her long-standing compensations are now failing her. The thought process behind this orthotic prescription is beyond the time and scope of this presentation, but it's fair to say this client was initially resistive to the concept of using an orthosis full stop. However, using G-WALK metrics, demonstrating how the data looks using video replays like this, and an overall desire to change the trajectory of her physical deterioration meant that she began to understand how wearing an orthosis could be beneficial for her ongoing mobility. Here is some gait data from Mrs. S's first walk for us. This table provides summarised data of the spatiotemporal metrics. You're provided with the expected range of normal for each parameter, and as you're getting to know the system, you need to pay attention to the units on the right-hand side. For example, step length is measured as a percentage of stride length rather than in centimetres or metres. We can see that the right step length is longer than the left. Typically, this is an indication that she's more confident on the left leg as the right leg advances. This is reflected in stance phase percentages as well. My basic first goal for Mrs. S's data is to increase her right stance phase value because that will reduce the duration that the left leg is on the ground and demonstrate how she's increasing her trust in her weaker leg. This will help achieve our goal, or our overall goal of reducing the load on the better leg. As I mentioned earlier, a known inaccuracy with contractions has given us an increased stride length, and this in turn gives us an elevated speed. However, these readings are directly comparable because they are recorded consistently, and whilst our clients like to know what's normal, we're looking at the difference we make to their normal. As a first-line intervention, we encourage Mrs. S to use a stick in her left hand as much as practical. We're expecting to observe changes in her truncal compensations and an increase in left step length. It's really quick to give her a stick and repeat the walking test with the stick. We can view the individual analysis, or we can jump into a comparison view, and this really makes it quick to see the impact of any intervention you make. So, for Mrs. S, we've prescribed a CAFO with a posterior thigh shell, anterior tibial shell, a unilateral double action ankle joint with dorsiblock and dorsi assist. Prior to manufacture, we called on head to foot orthotics to trial the SBL2 because her strength profile is ideal for the stance control system, but we were concerned about the functional implication of her flexion contractures. Thankfully, the SBL2 trial went really well, and we proceeded with the SBL2 stance control CAFO. I spent most of my time in G-WALK in the comparison view. So let's load up 4 conditions: unaided, walking with the left stick, walking with the right SBL2 diagnostic CAFO, and then walking with the right stance control CAFO and the left stick. In this comparison view, it's obvious that Mrs. S's gait is influenced by the different scenarios we've tested, but what I see here tells me that I've still got a lot of work to do. Unfortunately, stage 4 COVID restrictions that meant that we're unable to make all the fitting adjustments to her CAFO, and she's yet to be seen for her gait training. Not exactly ideal when I committed to presenting her case at AOPA 2020. We can see that in her videos, but we can quantify it with the G-WALK. So what we do have is data that will guide our fitting adjustments and gait training. Essentially, I want to be moving closer and closer and closer to what we've measured here in condition 2, walking with the stick. When we next retest her gait with the SBL2, condition 2 is currently her most efficient gait, but we want her to be walking efficiently with the added benefit of stance, knee stability, and reliable foot clearance. My understanding and appreciation of pelvic kinematics has also increased greatly since beginning to use the G-WALK. Have a look at these graphs that illustrate different pelvic movements. As expected, due to the flexion contractions, Mrs. S used more truncal flexion to achieve the knee extension moment to unlock the SBL2 before swing. We'll look to reduce the magnitude of the peaks and troughs during gait training and the fitting adjustments. We can gain insights into active hip flexion and extension, Trendelenburg compensations, and leg length discrepancies with these graphs as well. We will continue to retest with the G-WALK because the data is a good guide to the effectiveness of our devices, particularly for difficult presentations or if a lot of troubleshooting is required. And I only have the capacity to obtain this data because it's so quick and easy to use, and then repeat an analysis.